about, would this person be a good candidate for ECT?
Right. Yeah.
So ECT is, like I said, it stands for electroconvulsive therapy, and the major idea is actually to induce a short seizure under anesthesia medication. So we make a circuit with 2 electrodes in the brain that communicate with each other. And again, the patient's asleep under anesthesia for all of this. And the whole procedure lasts 10 or 15 minutes. From the time they go under anesthesia to the time we give them the ECT stimulus, we monitor the seizure with several different monitoring leads. And then they're back awake. And we have the anesthesia team and the psychiatry team there the whole time, monitoring things like blood pressure, heart rate, oxygen saturations, and we can intervene immediately if things kind of go in a negative direction. But Van is pretty healthy, which is excellent, and we would have her talk with the medical consultant before undergoing ECT, just to make sure that she's at the lowest risk possible for the procedure. So I think it may also be helpful just to kind of talk about common side effects from ECT if people have questions about that, and then the more rare but more serious complications from ECT.
Yeah, I think that's one thing that I've been worried about is the possible complications or side effects, and also I think comparing those to the possible ones from medication alone. I did want to think, like, is the ECT a replacement or standalone for medication, or how to balance those 2 things, side by side, so that it's not just laying on and kind of muddying the waters of any kind of condition by a lot of different treatment means at one time.
Yeah, so I will say that ECT works best when used in conjunction with psychiatric medication. And ECT it can be kind of a short-term intervention that we use to get, someone's symptoms under better control, and then we can kind of taper and actually discontinue ECT. And some people don't need recurrent courses of ECT. And actually, we see that medications like, some medications, depending on what they are, like patients have issues with tolerability or issues, being on medications for long periods of time. So in those cases, for people that are having really severe side effects or their symptoms aren't very well controlled with medications alone, we might consider ECT in that circumstance. So for now, I strongly recommend that we would use ECT in addition to the medications. But ECT may not be a thing that Van needs, like, lifelong in addition to medication.
Right.
But there is no cure for bipolar disorder. So this is like a chronic condition that would need to be managed over time, more than likely with medication.
Yeah. And the possible side effects, I think I've read there's components that involve memory loss, wondering the kind of predictability or length, or how to anticipate or manage that.
Yep. So that's correct. Short-term memory can be affected by ECT, and it's primarily while the person is getting the ECT. It's extremely rare that people have permanent memory deficits because of ECT. It's kind of worse when the person is in their acute phase or their index phase where they're receiving ECT 3 times a week. And then with time away from ECT, the memory should recover. The person may not remember periods of time during which they were receiving ECT. That's normal. But there's a lot of things that we do to mitigate the cognitive side effects from ECT. So a couple of things. We talked about when you make that circuit in the brain with the ECT electrodes to induce the seizure. For non-life-threatening cases, we would start with unilateral ECT, which involves just putting the electrodes and treating one side of the brain. for patients that have, you know, life-threatening
That's fine.
symptoms, we would, start with bilateral ECT where we treat the whole brain. And that's because psychiatric symptoms respond faster when we treat the whole brain. But when we only treat half the brain, the cognitive side effects are less.
Mhm.
So that's kind of the balance that we strike.
Here, we'll walk you out, okay?
Okay.
По-моему, чтобы говорить не могу дышать.
Not take your water. Okay.
Does anyone have any questions about that kind of a?
And do you know for how long this effect will stand with her, the ECT effect? Is it like something what she has to repeat time by time, or it's just one-time procedure?
Okay, so the average course of ECT is 6 to 12 treatments. That's the average index or acute course where someone's receiving ECT 3 times a week. So here at Salem Hospital, we do ECT every Monday, Wednesday, and Friday, unless there's a holiday. And her course will be kind of, dictated by how she's doing clinically. That's sort of how we decide how many treatments we need to go up until. And then after that, we'll recommend a taper. So we'll do ECT maybe twice a week for a little while, every week, every 2 weeks, every 3 weeks. The maximum interval in between ECT treatments would be 6 weeks. And then if someone's very stable and they've had no like regression in their symptoms, we could consider stopping ECT. And that's sort of the ideal course. Not everybody agrees to or is like it's not feasible for some people to like leave the hospital and come back you know, for ECT. So if that's the case, you know, and you can't kind of manage that nice clean taper like I talked about, some people can just stop ECT and not necessarily have a like regression in their symptoms. But that's the type of thing that, you know, she would have to follow with her outpatient psychiatrist for.
And is there a sense like how quickly you would notice if it was beneficial? I think that's where I get hung up a lot is I don't want to continue or start and continue something that it just isn't working.
Yeah.
And so is it, you know, you would notice after the first treatment, is this something that's actually doing anything?
So we actually have like a dose escalation protocol. So after like 3 treatments, if we haven't noticed any improvement, then we might talk about switching the ECT settings. And of course, with that kind of comes a higher risk of cognitive side effects, but we would certainly talk about that. We talked about as you change ECT settings, the symptoms get better, but at the risk of, you know, that temporary memory problem. And so it wouldn't be so much a question as, you know, is she not getting better? It would just be a matter of, do we not have the right kind of dose or the right ECT lead placement to like effectively manage her symptoms. But if we go through that whole dose escalation protocol and like we're doing if we like get up, God forbid, to the point we have to be doing bilateral ECT, and there's no efficacy whatsoever by like 9 to 12 treatments, then at that point we would stop and say, you know, this isn't doing anything.
And there would be the option to stop, like, basically, I'd assume Van's consent overrules the rest of the group, like,
Yeah.
stop,
Yes.
stop anytime if she becomes uncomfortable with it or doesn't want to go through with it, then even if we're kind of up until the moment of.
I mean, even the moment up,
Even
at
the moment,
yeah. If she's kind of up at the ECT suite and, you know, doesn't want, you know, to have any further treatment, we would just send her back down to the floor.
She decided voluntarily,
Yeah.
so, yes.
So
And like, Alana doesn't feel that she like grossly lacks capacity to make her own decisions, that, in some circumstances, and we're not talking about this for Van, but in some circumstances,
Yeah.
we have to like get a court
I,
order
I
involved.
have a question if it's possible. So is Carl have any weight on decision to continue or stop this procedure? So, for example, if Carl sees something, or it, his opinion is kind of counted in as a kind of weighted opinion in this for continuation or discontinuation of this procedure.
We absolutely, value everyone's opinion on how Van is looking and doing over the course. So we, appreciate the feedback. At the end of the day, though, because Van has capacity and she's a voluntary patient here, it is her decision. But, we want to work with you all, and if there's any concern, we can certainly have more discussions about stopping ECT or changing the course or what have you.
Okay. Okay.
That's a good question. So I'm still like with I guess the primary symptom that we are currently looking at ECT treating is what?
The psychosis.
Psychosis.
The disorganized thought process, the paranoia, the auditory hallucinations, and her mania symptoms are getting better. She's still like flight of ideas, but it's more like paranoidally psychotic. Yeah, and please share. This is your
Yeah. And I think psychotic symptoms because she has bipolar disorder.
Yes.
And ECT is a treatment for bipolar disorder. And I think if she just had psychotic symptoms and we didn't think it was due to bipolar disorder, it might be a more murky situation.
Yeah.
But I agree with you. I agree with the diagnosis of bipolar disorder. And that mood stabilization has been really difficult and not responsive to medicines.
also the catatonia aspect,
Yeah.
because she is on high dose benzodiazepines. We've tried to taper down, and we're continuing to try every day, but we're now at 8. So that's
So that's a really good example of like 8 milligrams of benzodiazepines is so much medication,
Yeah.
and it's not doing a great job. And so like she, is at risk for, like confusion, falling. Like I would worry about her like functioning out in the community, driving on that much medication. So